Welcome, everyone. I'm Dr. Timothy Deere in Charleston, West Virginia. And today we're going to have a scientific discussion of peripheral nerve stimulation. Some of the things we're going to discuss is chronic axial low back pain, central sensitization, and the proposed mechanism of action by which medial branch stimulation can impact low back pain when applied over a 60-day treatment period. You may have read some articles I've previously published on this issue. And now we're going to really dig deeper with some collaboration from some really brilliant people in the area of science. Dr. Josh Boggs, who's the Chief Scientific Officer at SPR, and two of his R&D colleagues. So with that, Josh, I'd like you to introduce yourself and your team.
Thank you, Dr. Deere. It's a pleasure to be here. And as you mentioned, I'm the Chief Scientific Officer and Senior Vice President of Research and Development here at SPR Therapeutics. And it's my honor to be here with you today, as well as two of my colleagues from Research and Development here. I'd like to introduce Dr. Meredith McGee and Dr. Nate Crosby. Dr. McGee leads our research in low back pain, and she's really been instrumental in developing our approach to place our leads to target the medial branch of the dorsal ramus for the treatment of low back pain. And she's also instrumental in the design and conduct of our clinical trials of percutaneous PNS for the treatment of low back pain. Also with us here today is Dr. Nate Crosby. Dr. Crosby leads our neuropathic pain research efforts and has really played a critical role, not just in neuropathic pain, but also really to helping us explore and further refine our understanding of the mechanisms of action and our theories around what enables percutaneous PNS to provide long-term pain relief with a 60-day treatment period.
Well, thanks, Josh. That's very helpful. And I was one of the early skeptics of whether we could change the neurophysiology of a nerve by doing something for less than a permanent implant. So I want to start off by discussing chronic low back pain and the 60-day treatment. And I want to really direct my first question to Dr. McGee. Meredith, you've been an important scientific part of this project in the low back. And, in most of our pain practices, low back pain is a significant problem, a common problem. And sometimes we disagree on the best approaches. So when we talk about peripheral nerve stimulation for low back pain, in your experience, I know you have a lot of it around the United States and elsewhere, what's been a good target for treatment of percutaneous PNS for the low back pain?
Great, thanks, Dr. Deere. So what we see in literature and what most people agree is that 70 to 85% of patients with chronic axial low back pain, there's really no clear underlying etiology or cause of pain that's easily identifiable. So there have been several studies that have shown that medical imaging or other diagnostic tests often don't really correspond well with the symptoms. And so many patients report significant disability or quality of life impacts without that obvious cause of pain or things that are inconsistent with the findings that we see on those diagnostic tests or imaging. So historically, the approach has been to subgroup or classify these patients based on diagnostic tests or imaging, but we still see a substantial percentage of patients who have pain that's recalcitrant to those conventional management strategies. So while some treatments are really well effective in well-selected patients, there continues to be a need for minimally invasive treatments that can be used earlier in the treatment continuum. And that earlier intervention offers the potential to prevent that need for, or even avoid those more invasive, permanent, or destructive interventions. And in fact, what literature also suggests is that part of the challenge in these patients with chronic axial low back pain may be the fact that these patients' pain is more likely to be centrally maintained than we previously thought. And so literature shows evidence of changes in central pain processing and central sensitization in these patients. And so what that does is it opens the door for us to think differently about how we might want to treat these patients, that is using new treatments that can address the changes in central pain processing. And given the recent advances in our understanding of the proposed mechanism of action of SPRINT, why it might be a good option for this patient population. So Dr. Deere, back to you. Sort of how does that compare with what you see in your practice for patients with chronic axial back pain? And how does that influence sort of who you choose for SPRINT?
Well, Meredith, I think it really compares pretty well. I think a lot of times, we have well-defined treatment algorithms. For example, we know when we have someone that we think their spondylosis, we're going to go to radiofrequency ablation. Or someone who has a peripheral nerve injury, we're going to go to dorsal ganglion stimulation. But patients with axial low back pain, when the pathway isn't real clear, has been the group I think that we're starting to focus on, because part of the challenge is addressing the centrally mediated mechanisms responsible for that pain to give long-term improvement. For example, you may do something that gives improvement for a week or two, but that's not going to change the person's long-term response. So, I think what I've been asking myself is, should we go earlier in some of these patient groups to the SPRINT technique early in the course of low back pain and maybe try to really change their neurophysiology to the point where we may actually get some cures. So that's what we've been trying to decide as we think about the algorithmic treatment of low back pain, the axial region. So that's really where we are at this point. So that really leads me to direct a question towards Josh. And you know, as a lot of our listeners out there will wonder about what the evolution is. You know, what's the genesis of exploring how some of these peripheral nerves to activate muscle could be really give sustained pain? I guess what I'm trying to ask you, Josh, is it the nerve stimulation itself changing the brain, or is it the nerve stimulation changing the muscles around the spine? What's that mechanism?
Yeah, thank you, Dr. Deere. That's actually a really insightful question. And to your point, and following with what Dr. McGee was mentioning, a lot of this of our understanding has really been based on several years of research and clinical studies and multiple RCTs to really help us understand that. And one of the studies that I think to help answer your question is worth highlighting is a study that was actually originally designed by Dr. John Che and our SPR Therapeutics CEO, president, and founder, Maria Bennett, several years ago. This study actually investigated patients with chronic shoulder pain. Essentially, to your point, these patients had biomechanical lack of stability in their shoulder. Essentially, these patients had subluxed shoulders where the shoulder had essentially moved out of joint. And so the concept in this study was to essentially stimulate the nerves, innervating the muscles around the shoulder joint, with the idea being that if there's instability there, let's stimulate those nerves and activate the muscles and move the shoulder back into joint, and that should treat the pain. Well, two things were really interesting came out of that study. One, it worked pretty well. The majority of the patients actually received very long-term pain relief. But the second thing was that the reasons that they saw that pain relief was not the reasons that were originally anticipated going into the study. And so if you take a step back and look at it in those two major thoughts, one is about 78% of these patients had long-term pain relief out to a year when they only had a little bit less than 2 months of stimulation treatment. So clearly, that combined with the fact we saw the same type of results in about 6 other studies really confirmed that this short-term therapy could really produce this long-term pain relief. But the second thing that really gets, I think, to the heart of your question, which is what's going on here? Is it neurological or is it biomechanical? Is about half these responders that had this long-term pain relief actually did not have sustained biomechanical stability long-term. To say it another way, about half these patients that had long-term pain relief, essentially their shoulder came back out of joint when the leads were pulled out. However, that did not impact their long-term pain relief. They still maintained that long-term pain relief up to a year or more. So understandably, this raised the question, sort of what's going on here? How is it working? And so analysis of these observations really led to a new hypothesis. The new hypothesis was that pain relief was not dependent on the biomechanics. It was not dependent on the stability, but rather on a neuromodulatory effect on the central nervous system. And the idea was that stimulating these nerves, these efferent nerves, cyclically could actually produce healthy muscle tension as the muscles contracted and relaxed. And that activation of the muscle would actually then generate afferent signals in proprioceptive sensory neurons. And that afferent activity would then be sent into the central nervous system to actually change the way the central nervous system is processing pain at a central level. Basically, the idea became, let's use muscle as a translator. So we'll stimulate efferent nerves, activate the muscle, and that'll generate afferent activity that then goes back into the central nervous system, really with a goal of resetting it, with an idea of trying to see, can we make the central nervous system revert to a more healthy, normal state, really in an attempt to break the patients out of this chronic pain cycle. Looking back on it, we realized, of course, as you know, that if this hypothesis turned out to be true, it could really open us up to treat a much wider range of patients, including patients with back pain, which, as you know, is what we went on to do under guidance from yourself and Dr. Chris Gilmore and many others. All that being said, you know, it's quite one thing to propose a theory and quite another to actually put it into clinical practice. So, Dr. Deere, I remember our team meeting with you several years ago when this theory was still very early. And I'm curious what your thoughts were, you know, and your impression then, and then, you know, if your impression has changed over the years as you've used the device both in the clinical studies and in your own clinical practice.
Well, Dr. Gilmore came to visit me in West Virginia last week, and we had time to collaborate and discuss these issues. And, you know, as I think you know, I always said we have to go with the data, and the data has to be good. And I think one of the reasons I've done so many prospective studies is I want to build that data. And so when, Josh, when you first met me, I think at one of the society meetings a few years ago, I was very skeptical about any type of mechanism that would work in the low back for peripheral nerve. Data in the shoulder was pretty good, and data in amputees were pretty good. And both those things I was optimistic about. But the skeptic in me said, there's no way this is going to work. And I think I told you that. And then, you know, we started getting involved in the studies, and we had several patients who had failed physical therapy, had failed medial branch blocks, and failed other avenues to treat their axial low back pain, had no surgical options, and really wasn't a great candidate for spinal cord stimulation because there wasn't the pathology there that I thought really demanded that type of therapy. And we went and put them into some of these prospective studies. And now we've seen several patients in our own practice respond both short-term and long-term. And certainly those who have good short-term response, who have some recurrent pain after that, would be a candidate for some form of permanent device for the same type of indication. So I do think we have both people who are cured over 60 days, and we have people who we can treat long-term. And this serves as a good message that they may be responders. So I think in both those groups, I've seen evidence building. I've seen good studies in both areas. And I really think that that's really where we're going to go for this type of syndrome in the future. So, I want to have a follow-up question to that for Meredith. Meredith, what's some of the early lessons you've learned? Because, Josh just asked me about what I've learned, and I've learned I was skeptical, but, evidence is turning my mind around. But as you advance this research, what have you found to be the most exciting aspects of what you've learned as you've seen more and more of these studies go forward?
Yeah, thanks, Dr. Deere. So going back to what we were talking about earlier about just this low back pain population that's difficult to treat, often we know that pain is nonspecific, and that is that there's no well-defined etiology of pain in a large portion of the back pain population. But what literature also tells us is that the multifidus muscle is dysfunctional or atrophied in a large percentage of that low back pain population. And so the multifidus, as you know, is that deep paraspinal muscle that's associated with spine stability, proprioceptive control, postural balance. And then literature also tells us that that atrophy and dysfunction is correlated with back pain. And so, therefore, when we were designing this approach and looking at how to translate the use of percutaneous PNS for the low back, we chose to apply percutaneous PNS to the medial branches of the dorsal rami because these are the nerves that innervate the lumbar multifidi. And so one of the most exciting aspects of this approach that we identified early on was that ability to activate the multifidi at multiple levels of the spine using only one lead on each side of the spine. So I really have enjoyed this simplicity and that elegance of the approach, but it's only possible for a few reasons. And the first is the design of the PNS microlead. And so that design of the electrode enables a remote selective targeting of nerves. So you can place the electrode up to several centimeters away from the nerve, meaning you can place simply without requiring that it's in intimate contact with the nerve like you might need to for RFA or traditional PNS. As well, the anatomical topology of the multifidus. So the way the multifidus muscle fascicles span multiple spinal levels, and they're innervated by multiple branches of the medial branch nerve from multiple levels, that recurrent innervation of the medial branches enables that when we stimulate at one level, it's translated and essentially sort of felt at multiple levels and turned into proprioceptive afferent signals that are transduced across multiple spinal levels, flanking the location of that lead. So altogether, what that means is that a single electrode on each side can be used to provide comfortable sensations across the entire region of that patient's axial back pain. So that robust activation of the medial branch and multifidus generates those healthy, normal proprioceptive signals that, based on what we see in literature with the atrophy and the dysfunction of the multifidus, those healthy signals probably haven't been present for a long time in many of those patients. So we've been really pleasantly surprised by the improvements that are reported even among back pain patients with heterogeneous symptom presentation, and especially among that nonspecific low back pain patient that you mentioned earlier that's been really historically difficult to treat. So it's been really rewarding, like you mentioned, to see the improvements in patients' lives and that excitement that comes for those patients that are several months to years out after that short-term 60-day treatment and continue to report how it was sort of a game changer for them. Dr. Deere, what have you noticed about patient receptivity to this approach with percutaneous PNS? How do you sort of approach it and present it to your patients?
Well, Meredith, thanks for that question. I think it's a great and interesting thing to ask. We found with ultrasound guidance that, as you pointed out in your last comments, that we see multifidus moving throughout the region, not just in the area of the probe. So I think that mechanism is certainly that you explained is accurate. And so when I talk to patients about this, certainly, there are several things that are attractive to patients I've found. One is this is a minimally invasive treatment. So a lot of folks are very attracted to the fact they don't have to be put to sleep or even heavily sedated for it. We also do it with no incision, with one needle on each side of the spine. So I think all of those factors patients are interested in. I think they're also very interested to learn that they actually can potentially have a treatment that may give them long-term improvement based on the current evidence. And I always discuss the evidence with the patient. What are we seeing in studies thus far? For example, if they've had a medial branch block that failed, in many cases, they haven't had a good option in the past. So now we tell them there's an additional option for them. If they've had ablation that used to last a year, but now it lasts 3 or 4 months, so they're not getting long-term improvement like they used to get, another group we may talk about in this philosophy. And then the younger patients, somewhere in their 20s, who maybe we don't want to go down the course of radiofrequency ablation so young, where we may be denervating the muscle. We're going to go in and stimulate instead. So I found that all those different groups are very attracted to the possibility of this helping them. And the risk-benefit ratio is quite favorable in most of those groups as well. So that's really how I've explained it. So let's go to the next question. Nate, you led the research into proposed mechanism of action. That paper we worked on in great detail, and your knowledge was so critical to its success. The mechanistic paper we published together a few months ago is now out for our colleagues to review and read. Can you explain to us in a nutshell, because that's a complicated really concept to really come to, how medial branch PNS may be having the sustained effects we're seeing with SPRINT? Well, in a nutshell, what's the mechanism?
Yeah, thank you, Dr. Deere. And it was a pleasure to work with you and the rest of the team of leaders in our field on developing that science and creating that manuscript that's now available. What that paper proposed was a mechanistic theory by which short-term PNS may be producing these significant and sustained long-term effects in patients, including those with low back pain. Now, as we've been discussing already here, and as you're well aware, Dr. Deere, a lot of chronic pain conditions develop a central component whereby the CNS structures, including the brain and the spinal cord, become involved in the maintenance of that chronic pain state. And it can really become a self-sustaining cycle that's difficult to break out of with conventional therapies. Now, historically, conventional neuromodulation approaches have sought to put stimulating electrodes in very close contact with their target nerves or neural structures, and that has limited the activation of the desired target fibers before reaching the discomfort threshold for a patient from the unintended activation of pain fibers. And so you end up with a lack of a robust activation of your targeted fibers that ultimately fails to mediate the centrally maintained pain state. And so patients who can get good relief while stimulation is running require something like a permanent implant to provide continuous long-term stimulation, and pain may fade quickly or over the course of hours or days if that stimulation is turned off or becomes no longer available to them. Now, the SPRINT system is designed, as you know, to be implanted and used for up to 60 days. And it's designed with a unique combination of features, including that lead that Meredith was talking about, a fine wire coiled structure with a single monopolar large electrode, and then also a stimulating waveform that all combined together enable us to place these stimulating leads remote from the nerve, a centimeter away or so, for example, producing what is a more robust and more selective activation of our targeted fibers before or while remaining below the discomfort threshold of the patient. So in the setting of low back pain, where we're targeting the medial branch of the dorsal rami, there are two main groups of fibers that we are seeing activated here. The first are those large diameter afferent sensory fibers, and these produce comfortable sensations that are commonly associated with neurostimulation. And then we also have large diameter efferent or motor fibers, whose activation produces comfortable cycling muscle activation in the multifidi in particular, which generate natural physiological signals through the proprioceptive side of the sensory system. That is to say that activating these large diameter motor fibers uses the muscle as a translator, to use the word that Dr. Boggs used a moment ago, to generate healthy physiological signals that the brain can really understand. And so together, activating these sensory and motor fibers in the low back can produce a healthy, more robust signal that the scientific literature suggests is sufficient to recondition the central nervous system. to really reverse some of those maladaptive changes that have encouraged the chronicity of the pain and the central maintenance of the pain to help break patients out of that cycle and to track for long-term improvement, even well at the end of the 60-day PNS treatment.
Nate, that was really helpful. I think the insight's really great. I think one thing you pointed out that I think was really important is that, in the past when we did peripheral nerve stimulation, we had to be basically touching the nerve. And even then, you were getting a paresthesia there overall. Now, with this new mechanism, that monopolar lead of all the properties you just discussed, we're actually seeing a larger field. So we're not quite as close to the nerve. And I think that's really led to some differences in the way we see the effect on the nervous system and potentially the central concept. So thank you for that explanation. I think it was very helpful. Let me just have some closing thoughts on this discussion. As physicians, I encourage our viewers to think more about syndromes like chronic low back pain, maybe centrally mediated. We always think about the peripheral, but I think when we affect the peripheral nervous system, we have to start thinking about what we're doing to the central nervous system. The importance of considering treatments like 60-day percutaneous PNS to recondition the CNS and provide sustained relief earlier in the treatment continuum. I think that these therapies may be more rehabilitative and less destructive. So certainly early on, we may find that they have better utilization. In fact, there are likely many more types of pain that are centrally mediated that we realized in the beginning, making this really an exciting time to consider this percutaneous SPRINT system in these conditions. So for me, I think now we're going to start rethinking about remodeling the nervous system in the periphery. I want to thank Dr. Boggs, to you and your team, Dr. McGee, Dr. Crosby, for sitting down and discussing this topic. I think we're in a new world of peripheral nerve stimulation, changing the central nervous system. I think this is just the beginning of an exciting era that peripheral nervous system treatment and implantation of devices in those areas can really change the way people suffer and really improve a lot of patient lives.
Great. Thank you, Dr. Deere.
Thank you very much.
Dear.